this is a story from Bangalore, and this was from our early days of our AI. So the clinician gets a call, the pathologist gets a call at 10 o'clock in the night. Okay, ma'am, there is a case which I need to look for malaria parasites, MP case. Can you help it? Can you please help it? So she actually went through the scans online, sitting at home. And the next day, she called us saying that this is the first time in my life I have confirmed MP sitting at home at 10 p.m. in the night. So this is solving for remote access. The pathologist need not be in the clinic all the time for diagnosis to happen. In radiology, teleradiology is the norm today rather than the exception. Unfortunately, not so for pathology. The pathologist has to be at the lab because the microscope is not digital, it is analog, the majority of microscopes. And remote pathology with the help of AI can actually solve the access problems to remote corners of the country. Another story from a large tertiary care hospital in Bangalore. Basically, she's treating cancer patients who have undergone maybe bone marrow transplants or intense chemo, and the total counts are extremely low, which makes it very hard to actually locate WBCs with the microscope and characterize them. And she's always apprehensive that she might have missed a blast. And the machine does it for her. And she's honest about telling us that, okay, machine does throw up false positives, but it doesn't matter. I can always weed them out. The machine is not replacing my intelligence. But it is actually picking up those blasts which I would have missed. So that's the value that the AI is adding to this particular pathologist. And then there is this perennial headache called platelets. Ask any hematology lab. And what is the biggest source of scourge in the lab? It is platelets. Come dengue season, you have tons of low platelet counts, samples, and many of them are spurious thrombocytopenia. They're not really low. It's just that the platelets have clumped, and the CBC machine did not pick them up. And the AI can do it. AI can detect the platelet clumps. It can detect the large platelets, which the CBC machine sometimes confuses with red blood cells, and reports it. And this is basically one of our customer labs. I've taken out the name, obviously, in Madhya Pradesh, who actually advertise this facility to their patients to bring in more patients. Another case from northern West Bengal, a patient comes in with low hemoglobin and low MCV. And the diagnosis was spherocytosis, and the AI picked it up without the pathologist having to spend even a minute on the microscope. And this pathologist on that particular day wasn't in that town. She was traveling somewhere else, and she saw the case, shared it with us, and wrote the report. So the key takeaways today for us today is basically that AI is a useful tool when it is built to solve the right problems. The keyword here is the right problems, which basically means that technologists in isolation cannot build AI for medical use cases. No matter how big the data set is, no matter how representative the data set is, it is the clinician, the radiologist, the pathologist who know what the real needs are. So it has to necessarily be a collaboration between the technologist and the medical professional. And I like to use this analogy a lot, is that the transition from AI to AI should not look like I'm driving a car today and I'm just sitting in the driver's seat and not driving it tomorrow. It should be like moving from manual transmission, which is painful, especially in Bangalore traffic, to moving to an automatic transmission, which may be lane change assist or automated braking built in. But the key word here is, again, we need to keep our eyes on the road and our hands up on the wheel, especially when human lives are involved. That brings me to the end of the presentation. I'm on time, so I'll be happy to take questions if there are any.